All right. I wrote my paper over combating increased intracranial pressure during intubation and airway management. The reason I did that is because I thought it was really interesting, and intubation does have a lot of possible negative side effects. So I did some research on that, and we'll go ahead and dive in. So we all know that intubation is a very, very important role as far as securing the patient's airway and keeping secretions from falling into the patient's airway, and pretty much an overall just hands down secure the airway technique. However, there's been a lot of studies that show that intubation doesn't really have a factor as far as morbidity or the instances of how often people die from whatever their condition may be. And some of the negative drawbacks of intubation are that it increases blood pressure and intracranial pressure, so which is significantly more important in our patients with head trauma or our possible stroke patients or anything else that might cause increased intracranial pressure. So some of the research that I looked up, it is an article called Rapid Sequence Intubation in Traumatic Brain Injured Adults, written by a host of physicians. It says the research that they found stated that intubation alone, while you're manipulating the patient's airway and their oropharynx and the trachea, there's a big pathway of nerves that stimulate both the sympathetic nervous system and the parasympathetic nervous system. And we all know that the sympathetic nervous system, when it's stimulated, it increases your heart rate, blood pressure, and things of that nature, while parasympathetic could cause bronchospasm. So we have the risk of causing both of those. Well, also, direct laryngoscopy causes a mean blood pressure increase of about 20 millimeters of mercury on an average. And then the research that I found on that, they said that hasn't been studies done on if it increases ICP directly, but endotracheal suctioning has shown to increase ICP by a minimum of 5 millimeters of mercury, and that's just the endotracheal suctioning. So I'm sure that intubation can cause significantly higher increases of ICP. So that's significant increase in blood pressure and intracranial pressure just from the effect of having the laryngoscope blade go into the patient's mouth. And that's something that we want to combat, and we can do that with different medications. Lidocaine is a very, very popular and traditional one. Fentanyl is another good medication to help prevent an increase in blood pressure by it kind of blocks the sympathetic response. Etomidate is another induction agent. However, that doesn't have any analgesic properties. So some of the things that we want to look at, after we intubate the patient, a lot of times past practice has always been to run their oxygen full blast. Let's get them up to 100%. Well, we know now that that is not effective. It is actually counterintuitive because it causes vasoconstriction in the brain, which again causes increased intracranial pressure. You reduce the size of the vessel, it's going to increase the pressure. It's just like for any firefighters out there, a good way that we relate it to hydraulics. Our smaller hose lines require higher pressures because there's the same amount of fluid going through it, but the diameter is smaller. And you're getting also less water, which we call GPM, which is another side point. But so we want to maintain their oxygen saturation at about 95 to 90, or I say 95, 96 to 99%. Once we get into 100%, you start bumping down the oxygen because we don't want to cause vasoconstriction. We can also cause nitrogen washout, which causes vasoconstriction in other areas of the body also. Now for pre-intubation, we talk about pre-oxygenating the patient as high as we can get them to give them a good reserve, and in those cases we do want that nitrogen washout, but I mean, you kind of want to be careful just how much you're giving them. So what are some of the signs and symptoms? How do we recognize increased intracranial pressure? So some of the more pronounced ones that I found by another study I found, and it's in my paper, I quoted it, but they're headache, vomiting, visual disturbances, diplopia might occur, which is a cranial nerve paralysis or palsies. The sixth cranial nerve is particularly vulnerable to stretch, while the third cranial nerve is at risk because herniation of the medial temporal lobe through the tentorial notch stretches the nerve as it exits the midbrain. Palsy of the third cranial nerve tends to be on the side of the lesion, whereas palsy of the fourth cranial nerve is non-localizing. The downward displacement of the brainstem and upper cervical cord through foramen magnum causes compression on structures that control cardiac and respiratory function. Critical compression may result in Cushing's triad of increased systolic pressure, including widening pulse pressure, bradycardia, and irregular breathing. And there's several brain herniation syndromes that were described. And should the patient present with any of those, we need to recognize that and take them to the appropriate facility, because if we don't take them to a hospital that has a neurosurgeon or can perform neurosurgery quickly, we could cost that patient their life, and whereas we could potentially save it and they have a good state of living after the event. So recognizing that and picking the appropriate hospital is vital. We need to be familiar with the signs and symptoms of increased intracranial pressure, especially when we're intubating, and know the medications to use to pre-medicate so that we can mitigate that as much as possible. So that's what my paper was about, and that's my presentation.